Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
This program is presented by Medscape Education Global.
Hello, my name is John Wilding and I'm Professor of Medicine at the Department of Cardiovascular and Metabolic Medicine at the University of Liverpool in the United Kingdom. I'd like to welcome you to this program entitled Obesity Care, Improving Health Outcomes in Collaboration with the Patient. Joining me today are Barbara McGowan, who's Professor of Endocrinology and Diabetes at Guy's and St Thomas's Hospital in London, UK, and Sean Wharton, who's Assistant Professor at the University of Toronto and a clinician and researcher in obesity medicine based in Toronto, Canada. So welcome to both of you. Today we're going to talk about obesity as a chronic and complex disease requiring long-term therapeutic intervention. The health benefits of clinically meaningful and sustained weight loss are really important, and we're going to talk about that in some detail. And then we're going to move on to how we should provide evidence-based healthcare for patients living with obesity. Now, obesity is a complex disease and it's not simply defined by the body mass index. Indeed, the WHO has for a long time defined obesity as abnormal or excessive fat accumulation that may impair health. And of course, we use body mass index, if you like, as a screening tool for obesity, with different classes indicating the different severity of obesity. But that does underestimate the complexity of the disease. Because it's not just about body size, it's about body fat in particular, and not just how much fat there is, but also its function and its distribution in the body and how that affects health. And that increase in adiposity that we see in obesity can affect health in many different ways. Firstly, we can have the physical effects of excess body fat, what we call fat mass disease, leading to pathology largely through mechanical forces. And then we have the concept of sick fat disease, fat that has become abnormal, leading to deranged endocrine and immune responses and inflammatory processes that result in conditions like type 2 diabetes and cardiovascular disease. So the complications of obesity can be considered in many different ways, but I like to think of them as those that are mechanical, metabolic, and those that affect mental health. And mechanical effects might include things like excess pain, osteoarthritis, or conditions like obstructive sleep apnea. The metabolic complications might include type 2 diabetes, an excess risk of vascular disease, metabolic associated fatty liver disease, and conditions like polycystic ovarian syndrome. And also many cancers are dependent upon the metabolic complications of obesity. And finally, we shouldn't forget that obesity can affect mental health, partly due to stigmatization, but also leading to depression, anxiety, and other effects on social and mental well-being. It's also important to remember that these factors often interact, and this can create adverse cycles of causation, with many of the consequences of obesity being present in the same individual. But Sean, I wonder if you can tell us a little bit about what the evidence is, not just that obesity causes disease, but that losing weight actually makes a difference to people's health.
Yeah, that's a great question, John. And really, we've known for a long time that people that are in a lower BMI status have less disease than those in the higher BMI status. But that being said, it's been difficult to show that if you move from a higher BMI down to a lower one, what type of disease prevention, what type of benefit will actually happen. So when we look at it, one of the things that we first see it in the first regards is that type 2 2 diabetes or glucose ends up getting better. So you can get a smaller amount of weight loss and glucose ends up changing. So about that 5% to the 10% changes, we see type 2 diabetes and glucose getting better. Now, when we look at other conditions such as osteoarthritis, we need greater amounts of weight loss. We're looking at the 10 to 15% weight loss. When it comes to cardiovascular disease and type 2 diabetes remission, 15% weight loss is often our target. So I think that's a number that we should look for clinically meaningful weight loss when it comes to these medical conditions.
And one of the things that I always worry about is in the trials and the observational studies that show this relationship between weight loss and outcomes is how long do you need to sustain that weight loss for? I wonder, Barbara, whether you could tell us a little bit about that.
So that's a really good question, John. And there is evidence to suggest that weight loss through lifestyle interventions can be beneficial in the long term. So let's take the example of impaired glucose tolerance. If we take the diabetes prevention program trial, in this particular trial, there were 3,000 patients randomized to either placebo, metformin, or a lifestyle intervention. The intervention was for 4 years, and the lifestyle intervention actually achieved greater weight loss compared to the placebo and the metformin arm. And this translated into a 58% reduction in terms of progression to type 2 diabetes. Good news.
Impressive, yeah.
So now there have been many trials in China, Sweden, Finland, many other countries, again, where a lifestyle intervention for up to 6 years had shown a reduction in terms of progression to type 2 diabetes if you have impaired glucose tolerance. And one of these is a Chinese study where there was a 6-year intervention. And despite the fact that there was weight regain after the 6 years, this translated into a cardiovascular benefit, sort of beyond 20 years. Now, not only that, the effect, although the intervention is only for a limited amount of time, let's say 6 years, the benefit in terms of progression to type 2 diabetes can actually last for many years. So again, if we look at the Chinese study, there was a 51% reduction at 6 years, but at 20 years, this was 43%, and 30 years, it was 39%. So again, evidence that the benefits is there in the long term.
So that's very interesting what you've shown with lifestyle intervention, but lifestyle intervention really only gives us 5 or 6% weight loss maybe at most. And there are interventions that are much more effective than that. For example, bariatric surgery. So what can you tell us about the effects of bariatric surgery in the long term?
So you're right that bariatric surgery can achieve greater weight loss. And we have good evidence from the Swedish obesity study, for example, which was a prospective study where patients were followed either through a lifestyle intervention or different types of bariatric surgery. And what the SOS study showed that, if we look, for example, at the Roux-en-Y gastric bypass, the weight loss 1 to 2 years is about 35%, but at sort of 10 years, 15 years and beyond, this is maintained at around 25%. Now, this translates into significant benefits because what the SOS study has shown is a reduction in overall mortality, but also a reduced risk of cancer, higher rates of remission of type 2 diabetes, and other health benefits compared to the lifestyle arm. So I've mentioned the SOS study, but there are other studies in the US and Canada, again, retrospective studies where they compare bariatric patients to matched controls, and these have also shown a reduction in overall mortality and cardiovascular risk.
So we've heard about lifestyle intervention being effective to prevent diabetes. We've heard about the very impressive effects of bariatric surgery on a whole range of obesity-related complications, including cardiovascular disease. What about pharmacotherapy? Sean, can you tell us a little bit about where we're up to with pharmacotherapy?
Yeah, this is a great question because it's very topical now. And because for the first time, we're really seeing that pharmacotherapy options are decreasing weight beyond that 10% range. So I'd previously talked about the fact that we need to get to 10 to 15% weight loss to really see the benefits in some of the medical conditions, particularly cardiovascular disease. So with the molecule semaglutide 2.4 milligrams, we're seeing in the STEP trial that that we're getting up to that 15% weight loss. So finally, we have an agent that gets to the weight loss capacity, and now we can see whether we're going to get the cardiovascular benefits. The SELECT trial took that semaglutide 2.4 over a long-term time frame, over 3.5 years, and looked at whether we can get cardiovascular benefit in patients without type 2 diabetes. And the SELECT trial was a trial, again, as I said, patients do not have type 2 diabetes in this trial. And why is that important? Because we know that when we decrease type 2 diabetes, the risk of cardiovascular disease goes down. So we'll see some cardiovascular benefit. But if you don't have type 2 diabetes, weight goes down. Are we going to actually see some cardiovascular benefit? And the answer was yes. We got a 20% decrease in cardiovascular disease. So that was 3-point MACE that we saw, a 20% decrease. And this was on top of the treatments that the patients had, which was aspirin, a beta blocker, a ACE inhibitor, a lipid-lowering agent. So they were on maximal cardiovascular treatment. And on top of that, this GLP-1 analog decreased the risk by 20%. So it's an exciting time for us now.
Absolutely. And of course, there are other agents in development. Do you know where we're up to with those, for example, with tirzepatide?
So if we really believe that weight loss was what drove the cardiovascular benefits, and we're seeing weight loss with tirzepatide up to the 20% range. So again, going back to the fact that we wanted to see 10, 15% weight loss, 20% weight loss is now here with this molecule. And that could very well translate into cardiovascular benefits, but we don't have the results from the cardiovascular outcome studies for tirzepatide as of yet. We're waiting for it.
Well, that's going to be very exciting when we do finally see that. Thanks very much, Sean. I mean, the reality, though, of course, is that weight loss maintenance for people living with obesity is very difficult because most people tend to regain the weight that they've lost. Let's hear about this from a person with obesity.
I have lived with obesity since childhood. Unlike my two brothers, they were the ones playing Atari and toy soldiers, and I was out playing tennis with my friends and running relays. But I was still the one that gained weight, even though we were a working class family and all had the same foods, same environment. I gained approximately 12 pounds per year from puberty, which was really difficult. And I shamed myself an awful lot for that. Constantly trying the latest diets, wearing a trash bag when I'd go out to jog to try lose more weight. I was the girl who was always trying to eat healthier, thinking that I was a failure. When it came to weight regain, I could lose 10 pounds, but I would regain 12 pounds. I would go to a diet program that my doctor would direct me to, and I would gain back after losing about 20 kilos, about 22, 23 kilos. And each time I went back into myself and I shamed myself and I blamed myself for that, not realizing that I actually had something called a weight set point. And this is something I needed to be treated for the rest of my life. Throughout my life course, I'm 47 years now in age, and I've lost the best part of, I would say, 190 to 200 kilograms. And I probably regained majority of that back throughout my life. I think probably one of the hardest parts of this journey has been having bariatric surgery as patient number 50 in Ireland at the age of 30 and losing half my body weight. I went down to my lowest weight ever of 88 kilos. And I felt invincible. I felt like this was it. I am fixed. This is life from now on. But I did not realize that, unfortunately, weight and obesity is genetic primarily in the female side of our family. And I was moving more than I ever did before. I was out dancing every weekend with my friends. I was in yoga. I was out with the kids swimming. I was doing things I could never do before. But then, even though my diet was like as healthy and still small portions and I was moving more, I started to regain weight. And in my own mind, I questioned myself again and again and again. What am I doing wrong? I'm a failure here. And that's when actually I went to my surgeon, and he said, Vicky, he said, it's been 15 years since you had surgery. If we give somebody a hip replacement, he said, after 15 years, we revisit that. Surgery and technology has changed, and we need to make sure everything's okay and probably revise it. And that's what we need to do for you with your surgery. And that was the first time I stopped blaming myself and thinking that, okay, so this was a tool. This was not the golden ticket to being at the right weight to fit into society's narrative, really.
So we've heard really how hard it can be to maintain weight loss, and people really do try. They have repeated weight loss attempts, and despite that, weight regain is very common. And we can see this from this range of 8 different clinical trials here with varying interventions, all effective at producing weight loss over a period of a year or more. But in the subsequent follow-up period, what we tend to see is that most people, most of the time, regain a significant amount of weight. And we also saw this in a diabetes trial, the Look Ahead trial, which looked at people with diabetes. And again, after 1 year, these people did very well with good support. They were able to lose more than 10% of their body weight. But the majority of these individuals actually tended to regain weight, although some were able to maintain weight, particularly some of those who achieved a greater than 10% weight loss early on during the intervention. Why is it that that occurs? Well, the reality is that this is a physiologically regulated phenomenon. As soon as we lose weight by restricting energy, by dieting, what happens is the body tries to return us back to our previous weight. And this is mediated via a range of mechanisms, including the hormone leptin from adipose tissue, reductions in various satiety hormones such as peptide YY and GLP-1, and the body tends to conserve energy. And all of this tend to make us feel hungry and eventually regain the weight that we've lost. So we do need to think about how pharmacotherapy can actually support dieting by helping people maintain that weight loss in the long term. So just thinking now about some of the practical aspects of obesity management, Sean, one of the things that I often find very difficult, and I know many clinicians also find difficult, is how to broach that subject of obesity. Let's say you're seeing a patient with cardiovascular disease. They've come to see you not necessarily about their weight, but about something else. How do you bridge that gap? How do you start to talk to them about obesity?
Excellent. Let's talk about that. Let's talk about how we start to talk to patients. So let's just say it's somebody who is a post-MI patient. They also have shortness of breath. They're coming in to see their healthcare provider. And so this person is living with obesity, heart disease, shortness of breath. Now, the thing to remember is that this patient is coming into us in a somewhat of a vulnerable position. And what I mean by that is that they think that everything that is related to their medical conditions is related to their elevated weight. They know their elevated weight is a problem, and they have been for many years told to just exercise and eat better. And they've tried that, and they've failed over and over again. They're hurt, they're in a vulnerable position, and they feel like nobody's helping them. So what we need to do to a large degree is to talk to the patient as a real person and give them the grand apology. The grand apology is that treating elevated weight has been shown to be beneficial for those with complications, but the way that we've treated people in the past was wrong. And treatment options have now improved, and the overall management is now patient-centered and in many instances can give the benefit of sustained weight loss. We're now in a position where we can actually help with weight over the long term.
That's very interesting, Sean, a fantastic approach. How would you actually practically advise a doctor to go about this? I've heard about this approach called the 5 A's. Tell us a little bit about that.
Right. So the 5 A's is an interesting approach to having a conversation with the patient. And each of the A's stands for a method that you are going to use. The first part of the A is the ask. And the ask part is really about compassion towards the patient. Now, we typically do not ask a patient if we can actually treat them. You're sitting in front of a cardiologist and you have heart disease. The cardiologist doesn't usually say, "Can I treat you for your heart disease?" That's why the patient's there. It seems a little odd. But here, in the weight management field, we actually should ask a patient, is it okay if we talk about your elevated weight? Is it okay if we broach the subject of treatments for your elevated weight? We can work as a team. If you do not want to move in that direction, that's okay. If you do, we now have options for you. So that ask is the compassion part. And we need to show that because we have not been compassionate in the past when treating people with elevated weight. The next parts of the A's is to do an assessment of the patient, and this is the individual assessment, not just a BMI focus. The next part is to talk to the patient in terms of advising them. What is the treatment option going to actually be? And sometimes it's a weight, and we can talk about it later, or we can talk more about it, but it's not always here as an agent for you. The next part is agreement between the patient and the doctor, not just on what weight does the patient want to get to, but what benefits are they actually looking for, and what are their challenges, what are their barriers? Can we have a reduction of those barriers, or can we get them to a stage where they can maybe do certain things that they couldn't do previously? And the final part is the assisting the patient. And the assisting means that we're likely going to get some of this wrong. And we need to go back to the beginning, ask the patient again, have another assessment, advise them again, and keep on doing that. As the patient moves along in age and stage within their life and their job profiles and their family profiles, they change. As a result, the treatment should also change. So we're always with them, and that's what the patient needs to know.
Okay, thanks very much. That's really important. Of course, many healthcare professions haven't had the training in how to do this well. So let's listen to our patient talking about some good and bad experiences they've had with healthcare professionals in relation to talking about obesity.
When it comes to engaging with healthcare practitioners, now that I'm older and wiser and I understand obesity as a chronic progressive relapsing disease, I don't judge them anymore. I've had some horrific experiences. When I was pregnant with my very first child, I was 24 years old, 2 years married, and I had to go alone because my husband was in work and he couldn't attend. And it was my first scan. And I was so excited to see my baby on the monitor and hear a heartbeat. And the midwife and the nurse asked if I could introduce medical students in, if that was okay for them to just see the procedure and everything else. And I said, absolutely, of course. At that stage, I would have been about 140 kilos in weight. And the gown didn't fit. And when she lifted up the gown, she kind of made these faces and sighs and puffs and huffs, and she put the gel on my stomach and she went around it with the scanner and she couldn't find a heartbeat. And she was huffing more and mumbling under her breath. And I was like, oh my gosh, is this because my child isn't here? Is something wrong? Actually, it wasn't. The penny dropped and I realized that the adipose tissue, which I carry predominantly on my stomach, was not helpful to her in locating my child. Finally, when she did find the heartbeat, I cried, and my tears were just of pure relief and not of happiness. And I just wanted to get out of there. The look of disgust on her face, as if to say, you're taking a child into this world with this body, was horrific. I could not get out of there quick enough. I didn't attend scans. I tried to avoid them at all costs because I was embarrassed, and I wouldn't bring my husband because I was ashamed. When my son was 11 years old, he had an ear infection. I brought him to the doctor. And as we're leaving, the doctor tapped him on the stomach and he said, lose that or it will kill you. And my son won't go to a doctor. He has been so shamed. But yet we've genetic obesity in our family. We cannot fight our own biology. Now, I'm aware that our healthcare practitioners, they don't get obesity disease education training. And that is a problem. And that is why I try to encourage my children to have conversations about it openly. Some of the best interactions that I've had have been with my revision surgeon, with my multidisciplinary team in weight management clinics, who actually treat obesity as the chronic disease that it is, and understand that I am on lifelong treatment, and therefore I will need treatment for the rest of my life. No different to if I had hypertension and I came off my hypertensive medication, and my hypertension would go up and I would need treatment. So it's the same for my obesity. And I'm just so relieved that there are some healthcare professionals out there that are aware of this.
Let's talk a little bit about what the options are that are available for people living with obesity who are seeking help and support.
So, of course, lifestyle intervention should always be the very first intervention for weight management. And what do I mean by that? Some, dietary changes, physical activity, behavioral change, addressing sleep and stress and, everything that affects everyday life. And that goes even, if you're wanting to do pharmacotherapy or bariatric surgery, this always needs to be sort of the wraparound, any intervention. But there are patients where lifestyle is just not enough, and we then need to consider other interventions, for example, pharmacotherapies. And now we have novel pharmacotherapies that can actually achieve double-digit weight loss and allow us to address perhaps some of those complications where more weight loss is required, as discussed by Sean. Now, what do we have at the moment currently available in terms of medications? Well, we still have orlistat, which has been around for a long time, and also other oral agents, including the combination of naltrexone and bupropion. These agents achieve single-digit weight loss, which is still good for some patients. And also, if we look at the sort of GLP-1 therapies, the daily injectables such as liraglutide 3 milligrams, again, achieves about a single-digit weight loss. The newer gut hormone therapies, GLP-1s and the GLP-1s GIP hormones now achieve double-digit weight loss. And Sean's already mentioned that tirzepatide actually goes beyond 20% at the highest dose. Now, even tirzepatide may not be enough for certain patients, and we need to then look at bariatric surgery, for example, or indeed some patients may not tolerate the medications, so we need to sort of consider all of these options and individualize care for patients.
Yeah, so that individualization of care is clearly very, very important, isn't it? Out of the new pharmacotherapy agents, we often hear about side effects of these medications. What do we really need to worry about? What do patients need to be aware of?
So the most common side effects for these new agents are gastrointestinal. So nausea, number one, and we absolutely need to explain to patients that they're likely to experience nausea, but that usually does get better over a period of weeks or months. So anticipating the side effect means that they're more likely to deal with the treatment. So on top of nausea, constipation, diarrhea, abdominal discomfort, flatulence, these are all very common side effects. Now, again, because of the side effects, it's important to titrate the medication slowly. So for the daily GLP-1s, the titration's usually every week. With the weekly medications, the titration is usually every month. But of course, you can go slower depending on how patients are reacting to the medication and what the side effects are. So it's, again, very much an individualized treatment. The other important aspect is to counsel them about the foods or the diet, because avoiding fatty foods, spicy foods can really help, as well as remaining well hydrated and avoiding alcohol and fizzy drinks. So all of these are little tips that can sometimes help patients. In terms of side effects, we have seen pancreatitis, but this is usually associated with any intervention which leads to weight loss, whether that's lifestyle, pharmacotherapy or bariatric surgery, because usually it's connected with gallstones, and gallstones can lead to pancreatitis. So as far as we know, there is no direct causal link between GLP-1s and pancreatitis, but it is something that they need to know about. So if they present with abdominal pain, nausea and vomiting, they should seek medical help. Women who are of childbearing age also need to use contraception, because we don't know what the side effects are of using these medications during pregnancy, so they need to be warned about this. I would also avoid using the medications in those with gastrointestinal diseases such as gastroparesis, because we know there is a sort of reduction in sort of transit times and gastric emptying. And finally, patients with a history of medullary thyroid carcinoma or multiple endocrine neoplasia should also, avoid using this medication.
So thanks very much, Barbara, for just describing to us the important side effects of these medications and what clinicians and patients really need to know about how to manage those with ongoing treatment. And that just makes me think a little bit about the importance of weight maintenance. We've seen this with bariatric surgery. Barbara's talked about that already. But I do think it's important that we remind patients and clinicians that these weight loss medications are not a quick fix. They do need to be continued long term if we're going to see the long-term benefits. And just as an example of this, in the STEP 1 trial, where patients were treated with semaglutide or placebo for 72 weeks, after the end of the trial, some of those patients were followed up without any continued support or treatment. And in both the placebo group and the semaglutide group, weight regain occurred, with about 2/3 of the lost weight being regained in the subsequent 12 months after stopping treatment, suggesting that ongoing treatment is required for long-term weight maintenance. A similar observation was seen in the SURMOUNT-4 trial, which was a long-term trial with tirzepatide, where after 36 weeks, some of the patients were re-randomized and switched to placebo. In the subsequent 12 months, weight regain occurred in those patients that were switched to placebo, whereas weight loss continued with then weight maintenance in those patients who continued on treatment. Final question to you, Sean. Some people just don't respond to these medications, or they get side effects, or maybe they don't really get the benefits that we would like to see in terms of complications. What's in the pipeline? What else is new that's coming along that might help people in the future?
And so, yes, I agree, John, that some people do not get benefit. And it's true that some people don't respond to the current pharmacological agents, or they don't respond in terms of weight loss, and they may not even respond in terms of the benefit, in terms of the complications. So we do need something else. And the good news is that we have many pharmacological agents that are in the development pipeline. And these agents actually promise to close that gap between the inability to lose the appropriate amount of weight and to benefit in terms of the complications. And so these agents include the oral peptides and oral agonists. They include newer dual peptides and newer triple peptides. So it's a really exciting time.
It really does sound like it's very exciting, and obviously good news for people living with obesity, that they will have so many more treatments hopefully available to support them in the future. So let's summarize what we've talked about today. Obesity is a chronic disease. It's characterized by significant medical complications which have multiple adverse effects on health. We've seen that weight loss can be beneficial to health and well-being in people living with obesity, but that it's difficult because of the multiple physiological mechanisms that resist that long-term negative energy balance that occurs with dieting. It's important also to remember that people living with obesity often experience negative stereotyping, stigmatization, and this can be exacerbated by the fact that many healthcare professionals have not had good training in supporting people living with obesity, and that makes it more difficult for those individuals to be able to access treatment. We do, however, have a range of effective treatments. Diet, lifestyle interventions supported by behavioural change have modest success and are still the cornerstone for all the treatments, including bariatric surgery, which of course is highly effective, but unlikely to be able to be applied universally at population level. To bridge that gap between lifestyle support and bariatric surgery, we now have a whole range of pharmacotherapies that can help weight loss and weight maintenance, and more recently have been shown to have beneficial effects on many obesity complications, including reduction in prediabetes, improvements in glucose control in people with diabetes, and reductions in cardiovascular risk factors, conditions like sleep apnea, and more recently, reductions in cardiovascular events. Barbara and Sean, thank you very much for a really great and stimulating discussion. It really was fantastic, and I hope that this has been really helpful to you, the audience, in helping you support people living with obesity in the future. So thank you very much for taking part in this activity. Please do continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.